Here, I think we're good. A little business first. If you have questions as you go along, please put them in the Q&A, and Dr. Canestraro will answer them at the end. Some recent news: the IBC conference was held at Villa Roma in Callicoon, New York. It was very well received, and it was a great way to get good CE in a casual setting. Next year, we are tentatively scheduled for the first week of May at a location to be determined, and we're going to be focusing on the needed education to get oral licenses. Also of note, Ropressa was recently approved by the New York State Department of Health. Now that we've got that out of the way, this month, Dr. Julia Canestraro will be speaking on ocular melanomas. Dr. Canestraro is an assistant attending optometrist at Memorial Sloan Kettering Cancer Center Ophthalmic Oncology Service. She has experience in the diagnosis of non-surgical management of ocular disease, including ocular tumors. She also specializes in treating the ocular consequences of cancer and its treatments. Welcome, Dr. Canestraro.
Thank you. Thanks very much. Can everyone hear me? I'll take that as a yes. Okay, great. My name is Julia Canestraro. I work at MSK. And so I'm actually in a unique position to be talking to you all today about new cancer drugs, what's out on the market, what's FDA approved, and why optometrists should pay attention. These patients are going to be sitting in our chair, and so it's going to be vital for us to know kind of what to look out for. So I always like to introduce my team. These are the ophthalmologists I work with. Some of the cases that I'm presenting today were also co-managed by them. And this is my disclosure statement. I have nothing to disclose. Okay, so we're going to start with the first class of drug, antibody drug conjugates, and we're going to go straight into a case. So we have a 48-year-old male who presents with no complaints. His medical history is positive for psoriasis, and he also has multiple myeloma, which is a type of blood cancer. And so he's starting a new drug called Blenrep. So we see him for baseline, pretty normal exam. Just want you to keep note of the prescription here and what his prescription was entering. So we kind of do a baseline, we make sure everything looks good, we clear him for drug, and then he gets started. He gets started on the drug. 1 month later, I see him, and his vision is down a little bit in each eye, and we see what we call peripheral MECs in both corneas. So we'll get into what exactly a MEC is as we go forward. But essentially, this is what they look like. So there are these small little cysts within the corneal epithelium. They do not stain. And so for this patient, this wasn't my patient. This is this is an example of a patient who looks similar to mine. But you can see here the MECs kind of are peripheral. And so that's how they typically present when they first start on this drug. These MECs and these little cysts are best seen actually on kind of like a sclerotic scatter type of view with your slit lamp, or even like a wider optic section. And you can see the cysts that kind of light back, but just again, keep in mind, these do not stain. So they can be kind of tricky to miss if you're not looking for them. Another thing I want to point out here is this huge shift in refraction. So when they first start on this drug, things go kind of in a hyperopic direction, just 1 month on treatment. So the treatment for this is just preservative-free tears. His vision's relatively unaffected. We know that this is expected with this drug. And we said, continue on with treatment and we'll see you back again. So 3 weeks later, patient comes back, vision's similar. And this time, though, the MECs are now diffuse. So they're not only in the periphery of the cornea, but now they're kind of scattered across the entire cornea. Thankfully, no staining. And so again, just take note of the prescription here. Things are now shifting back in the myopic direction. And again, this is only 2 months after starting the drug that the prescription has shifted like this. Treatment for it is just preservative-free tears as well. So we'll go on to case number 2. We have a 65-year-old male, has gastritis, hyperlipidemia, also history of multiple myeloma. He had a stem cell transplant, and so now he's relapsed, and he's going to be starting on this drug, Blenrep, same drug that we talked about in the previous case. This is his baseline exam, pretty unremarkable. 1 month later, vision is way down. Prescription has shifted in the hyperopic direction and also a lot more astigmatism, particularly in this eye here. And so in addition to having peripheral MECs, which we again expect the beginning stages of treatment, he also has diffuse grade 1 staining, SPK. And so because of that, we are going to treat with preservative-free tears, but I also added Restasis to help treat the dry eye component here. And so, sorry. Sorry about that. So we're going to treat with Restasis and preservative-free tears, and we'll see the patient back every 3 weeks, but I'm going to kind of fast forward 3 months from now to just show you how things look like when the patient has been on the medication for some time. So vision actually stabilizes back to closer to baseline. The MECs have now moved in location from peripheral to central, to diffuse. And the patient now only had trace fluorescein staining. Prescription now has shifted back in the myopic direction. And so we're going to, I wanted to show you here, this patient is one of my patients. And so the example here, you can kind of see the MECs, these little cysts, which kind of peek through the sclerotic scatter when you're looking through the pupil. And then you can kind of see some of this fluorescein staining here as well, but he had just trace staining throughout the eye, or throughout the cornea. So we're going to continue course for him. Preservative-free tears and Restasis. One thing I do want to mention is the location of staining and how it affects vision. So we'll talk about these refractive shifts, but we do know that patients have a shift in refraction. So why does this patient, or sorry, why in this first case, why was the vision down to 20/15, 20/70, whereas, you know, months later, the vision came back to 20/25, close to baseline, and it has to do with the staining. So in this case, the patient had coalesced staining likely in the center of his vision, which is what's affecting the visual acuity here. In this case, only trace staining. So even though the MECs are now diffuse, they actually don't affect vision with best corrected vision, I should say. So with a refraction, it does not affect vision. But it's the staining, if there is any staining, that's what's going to affect the vision. These are some other examples of patients that I have on Blenrep. I just want to kind of show you the variability and the different types of presentations that you might see on this drug. So a lot of patients tend to have this kind of whorl-like staining pattern. You see it here and here, kind of reminiscent of like a limbal stem cell deficiency. Some patients might have coalesced staining kind of more in the center, others not affecting the vision as much. So there's a lot of variability, and it can change even within the same patient, kind of follow-up to follow-up. So let's talk about ADCs. I wanted to kind of give you the case first, and then we'll backtrack. So ADCs are a new drug. There's a bunch of them that are FDA approved. They kind of started trickling in the mid to late 2000s. And then once 2020 hit, like 6 of them hit the market. These types of drugs actually treat many types of cancer. So it's not just one kind of cancer. They can treat metastatic breast cancer, lymphoma, multiple myelomas, cervical cancer. So you can imagine, the breadth of patients that these types of drugs are going to reach. These drugs here are the ones that I see most commonly. Don't worry about memorizing the names. Google is your friend. Google is my friend. And so if you're ever unsure about what a drug is, what cancer drug a patient is on, just look it up. And you just kind of look up, Kadcyla, mechanism of action. And if it says antibody drug conjugate, hopefully that'll click and you'll think about our talk today and think to look at the cornea. So these are the drugs that are currently FDA approved. Two of them, Blenrep and Tivdak, actually have a black box warning. So what that means is when the FDA approves a drug, if there's any severe side effect that the public needs to know about, it's going to have that written in a black box on the label. And so these two drugs specifically say that may cause loss of vision or change of vision while taking this medication. And so because of that, it's also required that the patients see an ophthalmologist or an optometrist every 3 weeks for clearance to obtain their next round of treatment. So let's talk about ADCs and how they work. So it starts with a tumor-specific monoclonal antibody. So this monoclonal antibody is designed to target a specific type of tumor, depending on the type of cancer you're treating. Then you have your anti-cancer agent, or the thing that's killing the cancer cell. We call it our payload. And then you have the chemical linker, which is kind of holding the two pieces together. So this is your cancer cell. The ADC binds to the target on the cancer cell. It gets internalized into the cell. The drug is then cleaved from the monoclonal antibody. The drug's released into the cell, and it causes cell death. This is an oversimplification, but just to get a sense of how targeted these drugs are. And so I think another reason why these drugs are so popular is because they are targeted. So chemotherapy, for example, kills everything. And there are a lot of side effects with chemotherapy. So with these medications, they're targeted, they're thought to be more effective in treating certain types of cancer. So now, why corneal toxicity? If they're targeted to treat cancer cells, why are we seeing these side effects in the eye? The short answer is they don't really know. It's still being investigated. But essentially, there are two types of corneal toxicity. You're going to have off-target corneal toxicity and on-target corneal toxicity. So if it's off-target, it means that either the ADC is binding to a corneal cell inappropriately, even though it shouldn't be, and so it's causing damage to that corneal cell. It could mean that the linker holding the payload and the monoclonal antibody together is unstable, and so it's prematurely releasing toxin and again causing damage to the cornea. But the most popular theory is that it's just due to payload toxicity, and so it's thought that the chemical that's used to kill the cancer cells is just so toxic that it happens to be killing some of the healthy cells around it. Again, these are just theories. Nobody really knows yet. The other reason why you can have corneal toxicity is because it's called on-target toxicity. And there are two ADCs, Kadcyla and Enhertu, which bind to HER2 receptors, which are found in certain types of breast cancer. But interestingly, HER2 is expressed in corneal cells. So these drugs do actually target the HER2 receptors in the corneal cells. And so because of that, it's likely a combination of off-target and on-target toxicity. So I decided to do a little experiment or a little investigating. Because these drugs are so new, there's really not a comprehensive database comparing all of the drugs. So there's a lot of, there are many isolated reports on these specific drugs kind of that the drug companies write, but we don't know much about kind of how they compare to each other. So what I did was I kind of categorized the drugs into their different payloads. So for example, Mylotarg has an ozogamicin toxicity or payload. Tivdak has an MMAE payload. Blenrep has an MMAF payload. And so once I separated them out, then I looked in to see how many of these drugs caused corneal toxicity and what's reported in the literature. And it's pretty scant, but essentially, this medication, there was one isolated report of keratitis. In HER2, again, another isolated case report. Tivdak did say that 11% of patients can have keratitis on patients that were in their clinical trials. Kadcyla can have up to 46% ocular toxicity, and Blenrep can have up to 71% corneal toxicity in patients. So there's obviously a large discrepancy and difference in incidence of keratopathy between these drugs. Maybe it's related to payload. So Blenrep is the only drug that has MMAF as its payload. Maybe there's something behind that. But what's interesting is both Kadcyla and in HER2, both which target HER2 cells on the corneal epithelium, have kind of varying incidences of corneal toxicity. So here, 46%, here I found one case report. So the short story is, or I guess the take home message here is that when a patient's on an ADC, it really depends on the kind of ADC that they're on in terms of how likely it is that they'll develop corneal toxicity, because they all act differently and they have different incidences of side effects. Okay, so what is a MEK? We've been talking about these MEKs. There's a proposed mechanism as to what exactly this microcyst-like epithelial change is. But essentially, the ADC somehow enters the corneal cell. It causes cell death. And then that cell that's dead is physically, you can visualize it in the cornea as this MEK. So this little cyst is just this apoptotic cell. The nature of how these cells progress actually does make sense. So they kind of start in the periphery and they move centrally. And so we know that our limbal stem cells are in the periphery. And if those cells are the ones that are taking in the drug, then that's where you're going to see the MEKs first. And then they're going to migrate to the center of the cornea and slough off throughout their normal cycle. So this is just a diagram that I took from one of the Blenrep papers. And essentially it shows here at the limbus, you have the drug here. The drug enters the corneal cells, the cell dies, and then it kind of follows its normal pathway to the center of the cornea and then eventually gets sloughed off. So as I was seeing these patients, I kind of noticed a trend in their shift in prescription. So we actually published something that describes the pattern that we've noticed. And so we looked at 28 patients on various types of antibody drug conjugates. And we mapped out the change in prescription that they had and also the change in keratometry readings. And we did find that the largest shift in prescription with these patients tends to be myopic in nature, sometimes up to 5 diopters of change in prescription or shift. And that also correlates with a steepening of their Ks. on average, patients experience a change in vision of 2 lines. Some people don't experience much change in vision, others experience larger shifts in vision. So again, this is just the mean. And that interestingly, when the MECs are peripheral, the prescription tends to shift in the hyperopic direction. And then as the MECs move more centrally, it shifts in a myopic direction. So what does this mean for the patient? What do I tell them? So they know that the drug may affect the cornea, and if it does, it can cause dry eye or blurred vision. And the reason why the vision gets blurry is because it can actually shift or change your need for glasses. And this can change often week to week. This might affect your ability to read fine print. And for some people, it might even affect their ability to drive, particularly depending on what their baseline vision was coming in. But I try to give them a silver lining, and I let them know that once treatment is complete, or even if it's paused for a long period of time, the changes are completely reversible. So everything goes back to normal. It can take time, for some people weeks, some people months, but things do go back to normal. So that's reassuring to some patients. There was one isolated report of a patient on Blenrep who developed a corneal ulcer. But again, these patients are monitored every 3 weeks. So if there is any, corneal compromise, it's something that we would get ahead of. So how do we manage these patients? So when it comes to their keratopathy and their MECs, currently the only thing that we recommend are preservative-free tears. And that doesn't even really help with the MECs. It doesn't do anything, but it might treat some of the dryness. It might make the patient feel more comfortable. I often prescribe, as I mentioned before, Restasis or Xiidra. For some people, they find that it helps with their dry eye symptoms. There's a big question mark around Predforte. So in the early stages of this drug, it was thought that steroids might have helped with the development or mitigating the MECs in the cornea, but recent studies have kind of debunked that. They're still looking into it, but I often don't prescribe a steroid. I've tried it myself just to see whether it helped at all, and I really didn't notice any improvement in the corneal appearance. Now, treatment and management for refractive error, I am open to suggestions because I don't have any good solutions for our patients, unfortunately. Because the prescription shifts so frequently, it can really make it difficult to manage. I had one patient who was just so desperate to have better vision that she bought a trial lens case to have at home. And I taught her how to make a trial lens, and she'd come in to see me every 3 weeks, and I'd write down her prescription, and she'd go home and make a trial lens for herself so that she could watch TV, so that she could read, and that she was happy with that. For some people, over-the-counter readers are helpful, particularly if the prescription shifts in a hyperopic direction. But again, that's only temporary. So monitoring these patients. I see a lot of them where I'm at, but a lot of these patients don't want to come into the city or can't be seen, or it's physically difficult for them to come in every 3 weeks to be seen. So this is where you might find a patient in your chair, and they may require this kind of monitoring. So the drug company does have a grading scheme, and essentially what you'll do is you look at the cornea, and you'll grade the keratopathy and also the change in vision, and you report the findings back to the oncologist, and they have a kind of a decision tree. Based on the grade, it will tell them whether they can give the next round of treatment or not. Now, based on experience, I know that if someone hits a grade 2 or more, they're going to probably hold treatment that week or even give it at a lower dose. So what I'll often do, If I have a patient where the cornea is in decent shape, but the vision has changed by 2 lines, I'll throw in a bunch of tears, get them behind the phoropter again, and really push them to read 1 more line so that I can keep them at a grade 1. Because I know that if they hit a grade 2, it might mean they don't get treatment that week. And that could be life-saving. So in terms of prevention for the development of NECs, again, nobody really knows. They're trying a bunch of different strategies. So it's thought that maybe the drug enters the cornea via the blood vessels in the conjunctiva. So they'll give brimonidine or a cold compress during the infusion to limit the amount of drug that gets to the eye. And again, back on these steroids to see whether that's helped as well. So these are all currently being looked at, but to date, we really don't have any good prevention for these NECs. Okay, so we're going to move on to the next class of drugs, immunotherapy. And so before I start this commercial, I don't know if you've all been in the same position, but you'll be watching TV and you see a commercial and you hear their long list of side effects, and invariably it mentions the eye, and you kind of, your ears perk up. And then I start thinking to myself, do I know this drug? Am I supposed to know what happens in the eye? And so these are just some commercials you might have seen. I'll kind of fast forward to the eye part.
Pain, nausea or vomiting, dizziness, fainting, extreme tiredness, weight changes, constipation, excessive thirst, changes in urine or eyesight, rash, itching, confusion.
Okay, so it talks about eyesight there.
Problems, muscle.
Oh, sorry. Okay, there was another, but you get what I'm trying to say. So those were commercials for 2 different drugs that are a type of immunotherapy that can have side effects in the eye. So I'll go through some cases and then we'll talk about immunotherapy and how it might affect vision. So the third case here is a 54-year-old female. She's got blurred vision, left eye greater than right, history of metastatic non-small cell lung cancer, treated with chemotherapy, but now she's on ipilimumab and nivolumab. Those are 2 types of immunotherapy. So you can see vision's pretty horrible in that one eye. These are the fundus images. It's kind of hard to see on the color, but on autofluorescence, it picks up this area of choroidal infiltration in both eyes pretty nicely. And if you zoom in on the nerves here, you can see there's some edema, but also just kind of like this thickening to the choroid around both eyes, around both nerves. So you do an OCT, and we see fluid as well in both eyes, more fluid here. Could be the reason why the vision's a little worse in this eye. So I'll give you the Cliff Notes version of this case. So when we see choroidal infiltration and bilateral papilledema in a patient with metastatic lung cancer, the first thing you want to make sure is that it's not a metastasis to the eye. So we did an MRI, brain and orbits, that was all fine. We even did some blood work to make sure it was nothing infectious or inflammatory. That all came back negative. So given our history with these drugs and knowing that it can cause this kind of inflammation in the eye, we deem this to be related to immunotherapy. And so this is treated with steroid. In this case, it would be oral steroids. So we treated her with 70 milligrams of steroids. A few follow-ups later, I think this was maybe the 2 or 3 month follow-up. You see largely a resolution of the choroidal infiltration in both eyes. Fluid's gone. And she was happy. So we'll talk about immunotherapy and checkpoint inhibitors, how they work. On the left here, these are the drugs that are currently FDA approved for the treatment of certain types of cancer. Again, don't worry about memorizing the names. You can Google it. And so in general, with certain types of cancer, sometimes our immune system is kind of dampened, and it allows the cancer cells to kind of spread and do what they need to do. And so the way that works is that the antigen presenting cells or even a tumor cell will physically bind to the T cell and render them inactive so that they can't do what they need to do to fight the cancer. So the way that these drugs work is they block these binding sites essentially. And so by blocking these sites, it allows the T cells to increase the immune response in the body and fight the cancer. And so these are the types of cancers that are treated with immunotherapy, lung and melanoma being the most common types. And so you can get a whole host of side effects from checkpoint inhibitors. So you can have a Graves-like orbitopathy in patients on immunotherapy. You can get inflammation of the eyelids. You can get inflammation of the ocular surface, like keratopathy, not the same thing as MEX. You can have an inflammation of the uveal tract. So you see a scleritis here, posterior uveitis, choroiditis. It can affect the retina, so you can have a retinitis. This is a immunotherapy-induced retinopathy. Down here is CME. You can have involvement of the extraocular muscles, so like an orbitopathy. You can have an optic neuritis and even a VKH-like syndrome. Thankfully, this happens in only 1% of patients, so it is rare, but it can happen. And these patients are treated with, let me talk about what this means for the patient. So as I mentioned, when I tell the patient kind of what to expect, it's kind of reassuring to know that only 1% of patients can get inflammation in the eye. But things that you might notice if you had inflammation in the eye, blurred vision, redness, light sensitivity, and if it happens, they know to come in. But in general, once treatment is complete or paused, and if we get the right treatment, i.e. steroids, then changes are reversible. So depending on where the inflammation is, you're going to want to treat with a steroid. And sometimes, often you'll pause the treatment. Sometimes we need to stop it completely. Okay, so let's talk about the third class of drugs that I want to chat about, and this is the MAP. These involve the MAP kinase pathway. So we have a 55-year-old male complains of intermittent blurred vision that seems to happen after each round of cancer treatment, and then it resolves within a few days. So his medical history involves cutaneous melanoma, and he's on these two medications, dabrafenib and trametinib. They involve the MAP kinase pathway, which we'll get into. So vision's pretty good. He does have evidence of a anterior uveitis in both eyes. So we'll just keep that in the back of our minds. But when we look at the eye, I mean, here it kind of looks fine, and there's nothing really jumping out at me. But then comes in the magical OCT, and you see he's got multiple areas of subretinal fluid. You can kind of see these pockets here. And so that's the right eye. That's the left. So this is quite classic for a side effect that's seen in patients that are on a MEK inhibitor. So we call this MEKR, which is MEK inhibitor associated retinopathy. And the treatment for it is actually to do nothing. So I know this might look a lot like central serous, which I guess when you first see central serous, you don't do anything about it either. So that's good. But this is not central serous. This is drug toxicity. And thankfully, this goes away on its own. So typically, after each cycle of drug, the patient might experience these bouts of blurred vision, but then the fluid resolves on its own. Now for the anterior uveitis, we did treat with a steroid drop. The uveitis is actually from a side effect of one of the classes of medications, the BRAF inhibitor, and the fluid that you see here is from the MEK inhibitor. But they all work in the same pathway, and I'll show you that in just a moment. So after 2 weeks of doing nothing, fluid's better. Now, we did start a steroid drop for this patient, and I know somebody might ask, well, how do you know the steroid didn't, help with the fluid? Well, firstly, I mean, I guess if it was central serous, a steroid would probably make it worse. But secondly, we've seen many of these patients who are just on MEK inhibitors who develop subretinal fluid, and we did nothing and it gets better. Okay, and then I think this is my last case. So this is a patient who complains of sudden blurred vision in the left eye. She had a history of recurrent ovarian cancer, and she's now on trametinib, which is the MEK inhibitor, one of the other drugs that the patient in case number 4 was on. So vision's really bad in the left eye, count fingers at 2 feet. And you see this. So she has a CRVO. You work the patient up, you make sure it's nothing vascular, you check her blood pressure. We ordered ESR, CRP, everything was fine. So again, given our knowledge of the drug and given that workup was negative, we knew that this was related to the MEK inhibitor. And so this is a good picture just to show the CME here from the CRVO. And so the treatment, this patient received multiple rounds of intravitreal Avastin. And with time, it got better. And vision was, I think, close to what it used to be, maybe a line worse from baseline. So how do these drugs work? So the MAPK pathway basically works by translating signals from outside of the cell to signals inside of the cell. And so when the signal goes into the cell, it goes through the RAS, BRAF, MEK, and ERK pathway, and it can affect things like gene transcription, growth, proliferation of the cell. And so this is a normal pathway that all of us have, but in certain types of cancers, this pathway, there's dysregulation to the pathway. And so things are just out of whack. And so cells are growing, and there's really no regulation of what's going on in the eye. So the way that these 2 drugs work that I mentioned is they essentially block parts of this pathway. So dabrafenib blocks BRAF, and then trametinib blocks the MEK. And by doing so, it's thought to, it works in treating the cancer cells, but it can cause some of these side effects. Now, interestingly, the higher up you block this pathway, the more likely it is that you're going to get all the side effects associated with any of these other drugs. So just an interesting thing to keep in mind. But what does this mean for the patient? So I tell patients who are on MEK inhibitors that 15% of patients can get fluid behind retina. It may cause blurred vision, but thankfully that fluid goes away on its own. There's nothing to do about it. You do not need to stop drug. And so this is often a big concern for many patients because obviously this is life-saving treatment and they don't want to pause their cancer treatment. So it's reassuring to them to know that they can carry on treatment even if they do develop some of this fluid. Less than 0.3% of patients might develop a retinal vein occlusion, that last case that I showed you. So it's really rare, but if it does happen, it can affect the vision significantly. And of course, just sometimes with CRVOs, only time will tell, depending on whether it's ischemic or not. will kind of dictate whether the vision goes back to normal or not. And then these are patients on the BRAF inhibitors. 5% of them may develop inflammation of the eye, which is what we saw in that second to last case where the patient had anterior uveitis. And that's easily treated with a steroid drop. No need to stop medication. So treatment management, I kind of just went over this. So for the retinopathy or the fluid, there's nothing to do about it. Retinal vein occlusion, you might refer out for an injection. And for the uveitis, you can easily manage with a steroid drop. Okay, so just take home points. And I know we have a bunch of questions, so I wanted to make sure we had enough time to discuss them all. But take home points, just be mindful of the medications the patient is on. Google is your friend. You don't have to know every medication name out there, particularly new cancer drugs. But just what I like to do is if there's a drug that I'm not familiar with, I'll Google the name and then write mechanism of action. And then it kind of points me in the right direction as to what kind of drug this is. And then so I know what to look out for. And then of course, you know, if let's say you see a patient with a CRVO and you don't think to ask about cancer medications, and you do a whole workup and everything's negative, maybe think to go back to that and ask again, or look at their medication list again, because that might be revealing. And then of course, you can always email me. You can ask me questions. I'm happy to chat about any patients you might encounter. Yeah, so I know that I probably see more of these than the average person, so I'm happy to help with any of that. These are my references. And I think that's it for my lecture, but I know there's probably a bunch of questions, so we can answer those. So I'm going to the Q&A. So I'll start with the first question. In reference to the peripheral MEX, is this microcystic edema? Did the corneal thickness increase? Yeah, great question. So it's not microcystic edema, but in our study, we did not have any pachymetry readings. So that was a real, you know, that would have been eye-opening, I guess, in knowing if perhaps the cornea was thicker or changing in, if the cells are larger, then that might change the shape and that might be causing these shifts in refractive error. So maybe it's another study we could do. Have we ever tried Miro drops or ointment? We haven't. That's a really good suggestion. We haven't tried it mostly because there's no evidence of edema, but it's an interesting thought. I might try that next week. What about trying disposable contact lenses? Can they make the MEX worse or act as a bandage? And if they work, it would be great to be able to shift the prescription easily. Yeah, so I did forget to mention this, so thank you, Dr. Thaw, for bringing up that point. For most of these ADCs, it's actually contact lenses are contraindicated, which is really frustrating because I don't think it's been formally studied. I think the drug companies just kind of, when they see changes in the cornea or epithelial defects, they err on the side of caution because they don't want any type of, I guess, bacterial infection while using a corneal, a contact lens. But so we're technically not supposed to be using it, but I wonder if it would act as a bandage. The other question is, if the drug is coming from the tear film, would you be making things worse by kind of keeping the lens on the eye and keeping the drug closer to the eye? So interesting thought. Next question, if a patient has an RVO, would you have them stop the MAP kinase drug? So it depends on how severe the RVO is, but for example, the case that I gave, that patient was held temporarily And then I think they ended up finding a different treatment pathway for the patient, so they didn't restart it. I do have another patient who I'm currently following who developed a smaller CRVO. We're pausing him for now, and he may actually resume the drug because he's been, the CRVO is resolving and his vision's much better. So there is a chance to resume drug once the eye toxicity is taken care of. Yeah, another question about Miro. That's a really good thought. I've never thought to do that. So I really might try that. And then I think there's some, I don't know if there are any other questions here. Would you recommend corneal topography and or pachymetry as a baseline? Yeah, I mean, it would, in the interest of kind of science, yeah, I think it'd be really interesting to know what the cornea looks like before and also during treatment. In terms of managing the patient, I don't know if it would really affect your decision-making in any way. And I think that's it for questions. Is there any other questions? Okay.
Going once. Well, thank you very much, Dr. Canistro. That was a wonderful
you.
talk, and we
Yeah.
appreciate you coming with us.
Great.
So
Thank
with
you,
that, we'll
everyone.
conclude tonight's presentation. Good night, everybody.
Good night.